So Charcot syndrome is a serious and life-threatening condition that develops in the lower extremity. We see it a lot in patients with diabetes, but patients with other neuropathy, either alcoholic neuropathy or other toxicities, or even neuropathy because of, the surgery or impingement in the back. But most commonly, we see Charcot in patients with diabetes. Patients with a history of diabetes and that peripheral neuropathy are a higher risk for what is called a neuroarthropathy. That's what Charcot is considered. It's also considered an inflammatory condition. And what develops is varying degrees of bony destruction, disorganization, and that leads to that rocker bottom foot appearance. It's usually caused by minor trauma, sometimes a major trauma, but it can be as simple as a screen door shutting on a foot. I've seen that happen before, or a patient kind of stepping off a step in a weird manner, and then it kind of just causes this cascade of abnormality of bone metabolism, and what patients will develop is this dysfunctional foot. Will have this midfoot soft tissue ulceration that could develop infection. And like I said, long-term amputation occurs in most of these patients. So unfortunately, Charcot is still a challenge today. There is little solid evidence on, like a gold standard treatment. Interaction of diabetes at sensory neuropathy, autonomic neuropathy, trauma, metabolic abnormalities, kind of like this perfect storm that leads to bone abnormalities. And the hallmark is that rocker bottom foot. There's no singular cause, as you can see, but once triggered, it's really a process of uncontrolled inflammation. The bone is fractured. There's release of these pro-inflammatory cytokines. With the patient's loss of sensation, patients kind of walk through it. They continue to ambulate and have these repetitive stresses, so the bones continue to break down, and we see this cycle of osteolysis or osteoclastic activity. Now, what we like to do when we catch this early enough, we want to immobilize the patient. We want to stop that walking and ambulation. Usually we do it by casting the patient and trying to get them to be non-ambulatory. There are some other medications or some IV medications that are showing some promise. But again, there's really no gold standard. And unfortunately, we tend to see these patients when it's kind of too late, when some of this bony abnormality and these poor processes have occurred already. So initially we see the Charcot manifestations as mild, but increase with repetitive trauma. There's been no reported cases of Charcot without neuropathy. And again, it doesn't have to be diabetic neuropathy, although that's the majority of causes. Sometimes it can be alcoholic neuropathy or neuropathy for other reasons. Early sign is usually local inflammation. And, it looks like cellulitis or DVT or even gout. So you have to have a high incidence of suspicion with patients with diabetes, especially those with uncontrolled diabetes and maybe a remote history of trauma or minimal history of trauma. And we can detect that there's a degree of difference in the temperature between two limbs. But really the dead giveaway is when pedal pulses of the affected limb are bounding. So that should be indication that, maybe there's a Charcot process.